Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different...
You'll hear each extract once only. Remember, while you're listening, write your answers on the question paper. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now turn over and look at the notes for extract 1. Extract 1, questions 1 to 12. You hear a GP talking to a patient called Daniel Anderson. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi, it's Daniel, isn't it?
Yes, Daniel Anderson, that's right. Hi, Dr. Hampton.
I haven't seen you for quite a while. What brings you in today?
Yeah, I probably should have come in before now.
Okay, well, that's fine. So how can I help?
Well, basically, over the last couple of weeks, I play football on Sundays, and a bit more than a couple of weeks ago, I was getting a bit more tired than I used to be. Like, I'd get out of breath in the game, I'd get puffed out. But more recently, it's been little things like walking up and down the stairs and stuff like that. That's got me a bit tired as well. So I was just wondering what's wrong with me, really?
Okay. When did you first start feeling poorly? Can you remember?
That's the thing. I had a cold, you see. Well, I thought it was a cold. I had a sore throat, and I was quite under the weather for that, but I've never really recovered since then.
And how long ago was that?
That'd be about a couple of months ago now.
Couple of months. Did we see you with that?
Well, so I made an appointment on the phone, but I didn't come in the end.
No, I didn't see you on the computer. So you just basically managed that yourself and...
Yeah, I thought it was getting better, but it's never really... I suppose that's never really gone away entirely. So maybe it was something more than a cold. I don't know.
Okay. What symptoms were you getting with that cold at the time?
Bad sore throat. My glands felt quite big as well. So I was just really tired, really, no energy.
Were you short of breath at that time during the cold?
Yes, but not as much now. That's why I've come in now, because it's gotten worse. It's got a bit more noticeable. But the cold symptoms have gone away now, pretty much. I still get a bit of a sore throat every now and again.
Right, okay. When you're at rest, do you get short of breath?
No.
No. Okay. Ever had asthma?
No, I've never had asthma or any sort of chest problems as far as I can remember. Nothing like that.
And do you have a particular diet? Are you a vegetarian or anything?
No, I'm not a vegetarian, but I hardly eat any meat either. I eat a lot of fried rice and instant noodles from the university cafeteria. The food's quite cheap. I know I should eat fruit and vegetables, but I'm a student. I suppose my diet is terrible if I think about it. Some days, all I'd have is instant noodles and some hot chips and the usual 4 or 5 cups of coffee.
You drink a lot of coffee then?
Yeah, it keeps me going with all the assignments and things.
Okay. Have you noticed any problems with abdominal pain or indigestion?
No, nothing severe, no.
Nothing severe? Have you had some from time to time?
No, not really. Well, I've had some mild discomfort occasionally, but that could just be indigestion, I suppose. I don't know, it's something I've had on and off for years, really. It's nothing new.
It's nothing new, okay. Any nausea or vomiting with this?
No.
What about your bowels? Have they been working normally?
Yes, been fine. I haven't had any diarrhea or anything.
In particular, not past any black or very dark motions?
No, nothing like that.
And what about family history? Is there a family history of people getting anemic, for example, for any reason, as far as you're aware?
No, not that I can think of.
No one's had any sort of blood disorders or anything?
No, nothing like that as far as I'm aware. My parents are very fit and active, and my brother doesn't have any health problems that I know about.
Right, so they're all fine as far as you know. So, Daniel, did you have an idea in your own mind what this might be?
I thought it maybe could have been related to the cold I had because one of my friends did have glandular fever around like a few months ago because my glands were up. I thought it could be related to that.
You hear a GP talking to a patient called Mrs. Wright. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. Afternoon, Mrs. Wright. I'm Dr. Kildare. Now, unfortunately, your usual GP is away today, so I'm going to help you if that's okay.
That's fine. Thank you for seeing me.
Okay, so I've got some notes, but it'd be helpful if you could tell me, in your own words, about the problems you've been having.
Well, Dr. Grimmett asked me to come back and check in about my foot. I've had gout, you see.
Okay, so just remind me, what happened with your gout?
Well, the first time was late last year, about 2 or 3 months ago. Dr. Grimmett had to treat me at home. It was pretty bad. I could hardly walk.
Oh.
We used steroids in the end to get a hold of it. I had the prednisone tablets, 30 milligrams for 5 days.
Right.
All the blood tests showed that I had the tendency to gout from crystals, so Dr. Grimmett gave me the allopurinol, trying to calm that down longer term. The doctor said to contact the clinic if it got worse, or come back around now just to check in.
Right. So we haven't seen you. Is that a good sign?
Well, I had, it was a good job I had the repeat prescription for steroids, because just after Christmas I had a bit of a flare-up again. I suppose I was eating a bit too much rich food and probably had more to drink than normal, but I have been watching it a bit. The doctor recommended I drink more water. He said 8 glasses, a couple of litres, and I've been trying, but it's a lot, you know, and I'm busy, so I don't think I drink more than 6 glasses through the day, but it's definitely more than before.
Right. Well, that's really good to hear. Water can definitely help, so it's great that you're keeping that up. Sorry, do you mind just describing where the swelling was when you had it?
Yeah, sure. Well, both times it started down the side, kind of at the base of the second toe on my left foot there, and then the whole foot swelled up across my smaller toes to the outside of my foot.
Ah, I see.
And both times I started getting a lot of pain, and it was all kind of spreading down from that area, and it went across the toes and started swelling up quite badly, really hot and inflamed. But it never goes to the big toe. So the second time, it never swelled up quite as bad as it did before, but I think I caught it in time when I went and got the steroid tablets from the chemist.
Ah, good. So how long did it take to settle down once you started the tablets?
It was a lot better than last time. I went straight back down within a week, so it was a lot better.
Right, and when it settled down completely, is it back to normal?
No, it's never been back to normal. I still have pain on that second toe where it always was right from the start, and I've still got it now.
Right, and how are you getting on with the allopurinol?
Yes, it seems to be better. I don't have any problems with it. I'm taking them okay, but like I say, that second toe is still giving me a little bit of a problem.
I see.
At the time, the doctor actually wondered if it might be a stress fracture, but I had a foot x-ray and that was clear. But I just think it's a bit unusual that it's still sore, and at the same time, everything points to gout. and the blood test confirmed that was the most likely thing.
Mm.
But that toe, it isn't the usual joint, as you know, for gout. It's usually the big joint, isn't it?
Yes, that's right. The big toe is typical.
But when I had the flare-up, the steroids really helped quite quickly. I stopped taking painkillers after 2 days at most. And I feel like it's less severe and we've got a hold of it better. So I guess that means the allopurinol is helping, right?
Yes, I think so. So I'm still quite keen to carry on with that tack.
Part B. In this part of the test, there are 6 short extracts relating to the work of health professionals. For questions 25 to 30, choose answer A, B or C, which you think best fits according to what you hear. Question 25. You hear 2 nurses talking about a plan for a citywide drive. Now read the question.
In order to commemorate World AIDS Day, Marvin asked that we organise a citywide drive.
Wow, that sounds exciting. So what exactly do we have to do? It's not actually a drive in a car, is it?
No, the 2 main goals are to test and educate. So I thought we could visit some local colleges, universities and businesses. We could host info sessions and a Q&A. Then we could follow it up with some voluntary tests and or impromptu counselling if need be.
I'll check my inventory for disposable test needles. How about you work on PowerPoint slides for the presentation?
I'll get right on that. It should be done within the next few days, hopefully, leaving me with enough time to work on what I'm actually going to say to the crowd during these World AIDS Day info sessions. Gosh, it's such a buzz connecting with our local community like this.
Question 26. You hear a conversation between a pharmacist and her co-worker. Now read the question.
Would you please help me sort these medications? Some of them have expired and now they're all mixed up.
Sure. Shall I start with A to H? And you can do I to Z.
Yes, that sounds like a plan. Thank you so much, Kate. And again, I'm sorry to have to pull you in over the weekend like this.
That's okay. I wouldn't have been doing much anyway, just helping out with my dogs. One of them had a nasty fall and we've had to get her a new collar.
Oh, ouch. You haven't left her alone, have you?
No, my partner's looking after her whilst I'm here. I know it's urgent and that we're short-staffed. What with Luis not being here again and all.
It's the 3rd time this month and I am really sick of it. No one else has been away as much, and it's driving me around the bend how much extra we have to do around here these days.
Question 27. You hear a team briefing where overall performance is being highlighted. Now read the question.
Thank you all for coming. I'll make this brief, shall I? My department has noticed an increase in the number of absences on the ward of late, and it is causing us some concern. This is a hospital, and when we are short-staffed, patient care suffers. With the HQC breathing down our necks, it's not something that we can continue to have happen. We are considering taking drastic measures in order to protect our patients and our reputations, and that may just include terminating frequent absentees.
Surely, that's a little harsh.
Well, it's a serious matter, and despite several disciplinaries, we've concluded that talking to them hasn't worked.
If I may offer a suggestion, I think that right now, I think it's a little too easy to take leave.
What do you mean?
Well, at the moment, we download a form off the internet and submit it to our line managers. Perhaps if it were a little more difficult, we'd have better luck.
Fine. I'll see if we can alter the current procedure slightly, and if that doesn't work, then we'll need to move to a plan B.
Question 28. You hear a conversation between two nurses. Now read the question.
Still here, are you, Linda?
Yes, I am. I'm on the graveyard shift tonight, Bobby. You're done now, aren't you?
Yeah, just finishing up some of my documentation from earlier, and then I'll call it a night. Just so you know, Bed 5's getting a little angsty about later. He's worried about how he won't be able to drift off again.
Can you blame him? He's really had a rough time this week. Wait, is he the hemophilic patient or the one with diabetes?
Mr. Wilson's diabetic. He'll need his insulin topping up, but that won't be until morning now. What time will you be doing the next round?
Midnight.
Okay, that's good. Please make sure you remember to disconnect Mr. Wilson's saline drip before then, otherwise he'll be fussing into the early hours. He's been assessed several times today, so he won't need any more of those, but everything else on his care plan needs to be attended to.
Got it. Thank you.
Question 29. You hear a morning briefing. Now read the question.
All right. Today we need to address some serious problems in this department. I don't know where to start, really. We've got so much that we need to remedy that it'll take weeks, if not months, to get us where we need to be. Ideally, we'll be able to increase the number of personnel devoted to the tasks we're working on, such as clearing up all the post-discharge paperwork that we've got piled up. However, I don't know if we'll be able to change people's job roles at such short notice. Never mind the fact that all of the larger rooms that would be able to accommodate large teams are all located on the other side of the ward. If anyone finds that they have a couple of hours spare this or next week, please make sure that you get in touch with either myself or Carla, okay?
Question 30. You hear a conversation between two nurses. Now read the question.
Are you coming to the school later? I've been asked to organise the vaccinations for the under-16s.
Oh, is that today?
Yes. Why? Will that be a problem?
Not really. I'm just trying to organise my day. Can I ask you one thing, though?
Of course.
We've organised tetanus vaccinations at that school before, if I remember correctly. Now, if they've all been immunised against the flu, why are we having to give H1N1 vaccinations today?
I wondered the same thing, and you know what? It beats me. But that's what it says on the chart, so that's what we'll have to give them.
All right, no worries. Give me 10 minutes and I'll clear up the rest of my day and prep to go with you.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear a healthcare practitioner talking about aspects of their work. For questions 31 to 42, choose answer A, B or C, which you think best fits according to what you hear. Extract 1, questions 31 to 36. You hear dietitian Catherine Weston delivering a presentation on diabulimia. You now have 90 seconds to read questions 31 to 36.
Hello, my name is Catherine Weston and I'm a dietitian with a keen interest in a little-known condition called diabulimia. The name is derived from a mixture of diabetes and bulimia, as it describes the situation where type 1 diabetics develop the behavioural characteristics of the aforementioned eating disorder. As insulin restriction is a significantly more dangerous act than calorie purging, the sooner something can be done about the countless lives being lost because of diabulimia, the better. To put things in context, it is estimated that approximately 400,000 people in the UK are living with T1. Whilst the exact number of people living with diabulimia is unknown, alarmingly up to 40% of sufferers, who are mainly female, aren't taking enough insulin to survive. With that acknowledged, it would be remiss not to mention that those affected are not exclusively women. A recent German study suggests that 11.2% of boys aged 19 and under are intentionally depriving themselves of insulin in a drive to be thin. Yet, despite the widespread reach of this condition, it is not as visible as other similar disorders, such as anorexia or bulimia nervosa. Part of the reason the condition is so low profile is the fact that the condition is not a recognized medical or psychiatric term, but rather it highlights the practice of reducing or eliminating insulin in a bid to lose weight. As diabetes sufferers cannot produce insulin but need it in order to survive, the practice of restricting their intake with the aim of losing weight is incredibly dangerous. Sufferers run incredibly high blood sugars, which has the potential to produce multiple irreversible diabetic complications. This can include neuronal, retinal and renal damage. The most common symptoms of the disease include irritability, decreased concentration and motivation, and diabetic ketoacidosis, all of which are analogous to diabetes. Rather eerily, by making the decision to cease treatment, sufferers are essentially turning the clock back on their condition. I do a lot of work with Diabetes UK in order to raise awareness of the signs and signals of diabulimia with friends and family of people with insulin-dependent diabetes mellitus. This type of outreach work was sparked by the many case studies of young people whose lives have been claimed by the disease. One such account is of the life of Amara, a 27-year-old who took her life after battling with the disease. Typically of people with the condition, Amara developed an unhealthy preoccupation with food. She also became increasingly uncomfortable taking her daily medication, comparing injecting her insulin to injecting fat into her body. Her sporadic insulin restriction then became a greater feature of her life. The unhealthy obsession with her diet led her to the discovery that despite not lowering her food intake because she had drastically reduced her medication, she was losing weight. The weight loss is a result of the body cells failing to absorb blood sugar, with the consequence of prolonged elevated blood sugar in the individual. This causes the organs to be saturated in glucose. Amara was found dead, having taken her life after a futile years-long struggle with diabetes. Her death highlights the crisis for the medical and diabetic communities, neither of which have the resources or systems of care in place to support such a nuanced disease. In fact, such tragic consequences are so severe and such stories are so tragic that early detection is a governmental priority. NHS England's clinical team have been involved in producing the NICE guidelines on eating disorders, devoting part of the report to managing people suffering from an eating disorder and diabetes concurrently. The guidelines have been distributed nationally in a bid to tackle the illness. Furthermore, the organisation is integrating psychological services with GP practices by placing 3,000 new mental health therapists and surgeries. In addition, other private and charitable organisations are also keen to play their part. A prominent example includes Jacqueline Allen, founder of national charity Diabetics with Eating Disorders. Allen is presently campaigning for the omission of insulin for weight loss purposes to be recognised as a mental illness. The theory is that increasing the condition's visibility, it will become easier to engage multidisciplinary teams, including endocrinologists, mental health professionals and specialists like myself who specialise in the condition, to provide a 360-degree treatment service. Until that is achieved, however, the road to medical and psychological recognition continues.
Extract 2, questions 37 to 42. You hear an interview with Dr. Janae Brown discussing a neurological condition. You now have 90 seconds to read questions 37 to 42.
Welcome to the Health Matters podcast. Joining me today is Dr. Janae Brown, all the way from the East Coast. Dr. Brown, thank you for flying in.
Thank you, Ricky. It's a pleasure to be here.
So I know that you deal with many neurological conditions, but I understand that today you'll be talking to our listeners about one in particular. Tell us, Dr. Brown, what is multiple sclerosis, and how many people have got it?
Multiple sclerosis is a neurovascular disease that affects the brain and the spinal cord. Usually, the nerve fibers of the central nervous system are protected by myelin. Myelin helps the nerve fibers to transfer messages faster between the brain and the rest of the body. When multiple sclerosis sets in, the immune system identifies myelin as foreign and in turn destroys it. The damage then interrupts the message pathway by suppressing the myelin completely or stripping some parts of it, leading to the formation of scars. The disease is lifelong once someone is diagnosed, though with proper specialized management, a person can survive for long. According to the United Kingdom's National Health Survey, there are more than 100,000 people diagnosed with multiple sclerosis annually.
Are there many risk factors of multiple sclerosis? And could you give us examples of the effect the condition can have on its sufferers?
Yes, there are several risk factors that are associated with multiple cases of sclerosis, such as gender, family history, geographical location, lifestyle, and vitamin D deficiency, among others. When the diseases are in one person in the family, the risk of passing the genes to the children is very high. Also, women are at a higher risk of developing MS. The risk is made higher due to the hormonal differences. Furthermore, in areas that are further from the equator, the risk of developing the disease is high in the regions that are more than 40 degrees. The condition affects people of all ages, but most people are diagnosed between the ages of 20 to 50 years old. In terms of lifestyle, smoking is also associated with the formation of multiple sclerosis, although admittedly more research is required in order to clarify the reason for this.
What are the main effects of MS?
MS affects the whole body depending on the nerve that is affected. Different nerves innervate different parts of the body. The main symptom is weakness or numbness in one or more limbs. This usually occurs on either side of the body or trunk, one at a time. When the optic nerve is affected, the patient may have prolonged problems with double vision accompanied by extreme pain. The person might also lose sight in one eye with time. The patient may experience Lhermitte's sign, that is a feeling of electric shock sensation around the neck during movement, as well as when one bends the neck forward. The patient may also present with a problem with their gait or body coordination. Fatigue and dizziness may also be a problem. When the nerves innervating the speech center are affected, the patient may develop slurred speech. The gastrointestinal function can be changed, as well as bladder function, especially in continence problems.
Would you tell us a little bit about the diagnosis procedure?
Early diagnosis is preferable, Ricky, before the treatment of multiple sclerosis. Diagnosis methods range from laboratory tests and imaging tests such as magnetic resonance. For laboratory tests, the spinal fluid is tapped and taken for culturing and sensitivity. The liquid is drawn after lumbar puncture and carried out using sterilized equipment. This helps in knowing whether the cause is due to infection or not. Imaging helps in understanding the extent to which the disease has affected the nerves, especially within the brain.
It's all so fascinating. So, Dr. Brown, would you talk to us about the treatment options, what they are and their main aims too?
Yes. MS is chronic, and treatment options mainly involve management of the symptoms. The goals of treatment revolve around ensuring that patients recover from attacks as well as recurrent situations, as well as slowing the speed at which the disease progresses. For the treatment of seizures, the patient can be given corticosteroids and plasmapheresis can be done too. Corticosteroids reduce the inflammation of nerves. Examples include oral prednisolone and methylprednisolone, given through the vein. The process is mostly used in severe cases of the disease, especially when the symptoms are not improving through use of steroids. Beta interferons can also be used primarily in the relapsing remitting stages of the disease when it is still aggressive. Furthermore, other medication like this can be used in various stages of the disease.
That is the end of Part C.